Welcome back, those of you. My name is Nafis, this is Karen, and we're going to be moderating this session. We're both representatives of the Society of Back Pain Research. We're due to start, so we would like to ask the first presenter, Akash Mane, to come up and get his paper ready to start at 1:45, please.
Good morning, everyone. Thank you for giving me opportunity to present in BritSpine. So, my name is Akash Mane. I'm a spine surgery fellow from Bharati Hospital, Pune, India. So,
sorry to interrupt. Can everyone hear? No. Try and speak a bit.
Yeah.
Sorry. Thank you.
Thank you. So, does MRI morphology correlate with the preoperative neurological status in surgically treated lumbar spinal stenosis patients? So, introduction. With rising advancing age in elderly population, the prevalence and associated clinical disabilities related to the lumbar spinal stenosis is on the rise. The relationship between the MRI findings and clinically symptomatic LSS is a matter of debate. Boden shows 21% of the asymptomatic individuals over the age of 60 years will have evidence of LCS on MRI scans. Nevertheless, it has been clearly established that imaging diagnosis of spinal canal compression does not always correlate linearly with the clinical severity of the syndrome, and that none of the quantitative parameters of spinal canal measurements have bearing on the disease severity. Decision to make diagnosis of LCS on the basis of imaging has also been presumed dubious. So currently the surgical decisions are made on the basis of subjective and objective clinical features, and radiological diagnosis is of value to only confirm the clinical diagnosis. So objective of the studies: compare 4 established radiological schemas with neurological deficit status in surgically treated LSS patients. Identify which classification system most accurately correlate with the motor deficit in LSS patients. Material methods: study design retrospective cohort study comprises of 100 patients. Inclusion criteria being age more than 18 years, male and females both, with clinical and radiological features due to the degenerative lumbar spinal stenosis. Exclusion criteria: tandem stenosis, congenital developmental stenosis, and revision surgeries. So let's see the demographic data. In our study, mean age was 61 years, sex 47% female and 53% male. So this is interesting. So the motor deficit, out of 100 patients, we had 64 patients who did not suffer from motor deficit, and 36 patients out of 100 had varying degree of motor deficit. And sensory deficit, out of 100 patients, we had only 25 patients who had sensory deficit. But bladder involvement, only 7 patients out of 100 patients. So we considered axial T2 images for the study. All the patients were evaluated preoperatively by 1 clinical and 4 radiological LSS assessment tools. That is Swiss Spinal Stenosis Questionnaires, which has 2 components: pain severity and physical function score. And total score of SSS was divided into mild, moderate, severe for the ease of statistical analysis. So this, because of time-bound frame, I'll just go quickly through this. So this is Caesar's classification, Minskin-Mandel, Lees, and Menon et al. We considered all 4 classifications which is commonly used. So according to this classification, we divided patient into mild, moderate, severe grades. So distribution of the patient with sensory and motor deficit. So out of 36 patients who had motor deficit, out of 36, 20 patients had combined sensory loss and motor deficit. And out of 36 patients, 16 patients had isolated motor deficit. And about sensory loss, 25 patients, out of 25 patients, 5 patients only had isolated sensory loss. So results: the association between motor deficit in Caesar's grading and according to Lee's grading was not significant. The association between motor Minskin-Mandel grading and association between motor deficit with the Menon et al. Schemas, it also not significant. P-value was not significant. So, and now association between Caesar's grading, Lee's grading, Minskin-Mandel, and Menon et al. Classification with the sensory deficit, it is also not, is found to be non-significant. So let's take a case scenario. So I'm sure that 90 to 95% of the surgeons over here would go with the operative treatment for this kind of image or this kind of patients. So 61-year-old male, back pain with bilateral lower limb radicular pain with neurocaloric distance 100 meters. According to Caesars, Lees, Miskin-Mandel, and Menon et al., it is filling in grade D, grades 3, severe and pinpointed. That is severe grade, basically, falling in severe grade. So on examination, but in spite of such a severe compression on T2 weighted image, you will find that there is no motor strength is 5/5 and sensory and bowel battery intact. So SSS tool that we used for the subjective findings, the pain severity of the patient, he falls into severe category, and functional disability domain, he had severe functional disability. That's why we operate this patient. Let's take a second case scenario. So this is the image of T2 axial. If you can see,
if you can start,
as compared to...
Sorry, if you can start making your conclusions, please.
Sorry, sir?
Start making your conclusions, please.
Yes, conclusion. Yeah. So we compared the 4 classification systems. None of the classification system, existing classification system, demonstrate or correlate with the neurological deficit and clinical features of the patients with radiological morphology. The conclusion of the patient, in patients with lumbar spinal stenosis, MRI morphology and severity of the stenosis did not correlate with the preoperative neurological status. And MRI morphology also does not correlate with the patient's symptoms and disability. So generally, should I?
Thank you.
Thank you. Thank you.
Can I invite questions, please? In which case, could I ask you a question?
Yes, sir.
We know and we see patients with severe central stenosis who are, as you yourself have shown us, quite asymptomatic. Was there a difference between those patients who had more of a lateral recess stenosis and their presentation as opposed to those with central stenosis?
So in lateral recess stenosis, basically patient will have unilateral radicular neurocalorication, unilateral. And central stenosis patient will mostly present with bilateral radicular pain.
Sorry, I meant with their degree of stenosis and their the findings on examination. As in whether or not they had motor or sensory changes.
Sorry, I didn't get you, sir. Okay.
I'll take it up with you later. I'll invite the next question.
Yeah, thank you.
Hi, thanks. That was a really interesting talk. Did you think about looking at the neural structures rather than the anatomy? So were there any T2 signal changes within the nerves that could predict for symptoms rather than just looking at the degree of compression?
Can you please be loud, please?
Did you think about looking at T2 signal change within the nerves rather than looking at the anatomical space in the spine? So the classification systems that you used, I think from just Googling them quickly, were looking at the degree of compression, but they weren't looking at the neural structures themselves, were they? Or were they?
Basically, in this classification system, every classification system is different. In Menon et al., we usually see the morphology of the T2 images, like pinpoint, complete block. And other classification system like Lees, Miskin-Mandel, we usually go with the CSF and root-late ratio. We see. And
my point was, were you looking at any of the...
I'm really sorry. We're going to have to leave it there. Maybe we'll take this up in the lunch break. Thank you.
Thank you. Thank you.
Okay. Would we ask Nitin Adsal, please, to come up?
Hi, I'm Nitin, currently working as a fellow in Leeds. I did this study while doing the fellowship in South Korea. So basically it is selective superior articular process resection foraminotomy for degenerative foraminal stenosis. So this is Anthony Yang's paper showing the patient who has got the disc asymmetry. There is the superior articular process which is pressing on the foramen and the nerve, and these patients have got more of the radicular pain. There are few studies showing the transforaminal technique is better in this patient, but if the patient has the lateral recess stenosis plus the foraminal stenosis, then you can tackle using the interlaminar technique. You can do the central decompression, lateral recess decompression, and then you can knock off that superarticular process as well. So everything you can tackle through the same approach. So this is the schematic representation showing the superior articular process and the amount of the decompression we do during the endoscopic procedure. And this is the again the image showing the superior articular process removal. So we included the patient who has got the wedging of the disc, foraminal stenosis, no instability, and who has got a follow-up for 6 months, and we completed all the radiological imaging. We got the CT scan, the MRI at each follow-up. The clinical parameters included in the study are VAS, ODI, and the McNabb grading. And then X-ray measurement, we did the check the lateral wedging, disc height, whether it is changing, and then we did the dynamic X-rays just to check for whether there is any increase in the instability in the post-op, and calculated the foraminal volume and the facet joint length on the CT scan. So I'll directly go to the few of the case examples. So the patient with the foraminal stenosis, I don't know whether it is clear, but the post-op image showing the increase in the width of the foramen, 6-month follow-up. The second patient, same thing, the supraarticular process causing the foraminal stenosis. The 1 week post-op and the 6-month follow-up X-ray showing the adequate decompression at the foramen. So we included the 19 patients with 20 level, 12 of the females, 7 of the males. The VAS ODI significantly improved pre and post-op. The McNabb criteria, which was excellent in the 4 patients, good in 14 patients, and fair in 1 patient. The foraminal width was significantly improved pre-op and post-op. There are few changes at 1 week and the 6 month, but they are not statistically significant. The facet joint volume was maintained, and the lateral wedging instability was not increased after the surgery, and the disc height was same. There was no instability, though our follow-up was only 6 months. So again, the lumbar lordosis increase, maybe that was because of the stenostic symptoms was gone, and there was no instability. So this is the surgical video showing the drilling of the superior articular process under the endoscope done by only one surgeon at the single center, one surgeon procedure. We have done this ESAP. So this is the removal of the ligamentum flavum in the foramen. And after remove the flavum in the foramen and cutting the ESAP, then you can see the nerve root. You are very close to the nerve root, so you have to be very, very careful. So this is the L4 nerve root. We're going from the contralateral side. So this one more case example showing the increasing the volume of the foramen. Central decompression as well as the contralateral foraminal decompression in this case. So to conclude, in view of above results, the uniportal full endoscopic facet joint preserving selective superior articular process resection foraminotomy for degenerative foraminal stenosis can take a good clinical result. This is believed to be helpful in treatment of the spinal diseases in the elderly patient where they are not fit for the major spine procedures and they have got a foraminal stenosis because of the lateral wedging. Thank you.
Thank you. Are there any questions? Thank you.
Thank you so much for your talk. I've seen on the post-operative images that you've shown that you are essentially decompressing the foramen in the anterior-posterior plane. But many times the foramen height is reduced in a sagittal dimension. So can you increase the vertical height of your foramen?
Yeah, so thanks for the excellent question. So basically once you remove the superior articular process, that is the medial lateral volume as well as the superior and inferior volume can be increased as I shown in the post-op imaging.
Could I ask, did you have any complications during?
Not major complications, but one since we are working near to the nerve root, the few patients, the 2 patients had dysesthesia, which got improved after a few days, but there was no dorsal root ganglion injury during the operation in any of the 19 patients.
So nothing long-standing?
Second.
No long-standing complications then?
No, because the follow-up is only 6 months. That may be a limitation of the study.
Okay, thank you.
Thank you.
Any other questions? No? Thank you.
If I could please call Christine Lemaker to come and present her paper next.
Thank you. So it's my pleasure to talk today about understanding how potential cell therapies can work within the harsh environment of the intervertebral disc. So we're looking here at intervertebral disc degeneration as a potential target for treating low back pain. And the reason we're targeting this is because this is a major cause of low back pain, particularly in those individuals which have the longest years lived with the disability. So in individuals which are aged 55 and under, show the strongest correlation of disc degeneration and low back pain. And I also have invested interest, because this is my spine, and I really need a bit of a better treatment. So if we look at degeneration of the intervertebral disc, the normal intervertebral disc has a gelatinous nucleus pulposus that consists of lots of proteoglycans that holds on to the water. As this degenerates, you get a cellular change within the disc, and you get a decrease of these gelatinous proteoglycans, and the disc becomes much more fibrotic. So at the mid to moderate stage of degeneration, this is where we could have the potential to regenerate the intervertebral disc, and with the aim to turn it back into a more non-degenerate hydrated disc with the appropriate functions. One potential cell source is those of notochordal cells. So notochordal cells are the progenitor cells of the nucleus pulposus. But in humans, we lose these cells around the age of 10. In animal models where they don't lose notochordal cells, these animals do not undergo natural disc degeneration. So this is why notochordal cells have been proposed as a potential cell source. Notochordal cells have been shown to have a number of anabolic effects and anticatabolic effects, either via the cells themselves or secreted factors, demonstrating increases in matrix production, inhibition of catabolism, via the release of trophic factors, and also potential to inhibit angiogenic and nerve growth into the degenerate disc. However, data to date has shown differential results, and a lot of this depends on what species of cells have been used, but also the culture conditions that the studies have been performed under. If we look at the human intervertebral disc, this is actually quite a harsh environment for cells to survive. In a normal disc, we have low oxygen, low glucose, and a slightly acidic environment. In a degenerate disc, this gets a whole lot worse. Particularly the pH drops considerably, and it becomes a much more acidic environment. So if we want to try and evaluate cell sources for regeneration, we need to know that these cells are going to be able to survive within these environmental conditions of the intervertebral disc. So we've developed cultured medias which can mimic these conditions much more closely. What we did was then take these culture medias and first of all investigate how natural MP cells, so the cells of the natural nucleus pulposus, survive, both from non-degenerate cow tails and from degenerate human cells. And what we showed, if we look at the degenerate MP cells, there's actually very little effect in the healthy and degenerate environment, and we only see a detrimental effect when you add in a physiological concentration of interleukin-1, with a decrease of collagen type 2 seen. However, we didn't see much change to the catabolic factors, such as MMPs and cytokines. If we look at the human disc cells and culture these and look at a whole host of secretome, so on this image, green is good and red is bad. So what we see is in the healthy and degenerate conditions, there's actually not that much change towards a degenerate phenotype. And it's only when we add in interleukin-1 into these conditions that this gets worse. Now, of course, these are degenerate cells taken from a degenerate environment, so it might just be because they're in the environment that they're used to. If we look at the notochordal cells as potential therapy, both how they behave within these culture medias, but also their influence on native MP cells to see whether we can use these cells to inhibit the catabolic responses. Here we've looked at the condition matrix, which is NCCM, and also the cells themselves to investigate their responses. First of all, the cell's behaviour within the actual medias alone. First of all, they survive, so notochordal cells are quite happy within these different conditions, and we only really see some loss of viability when you add in interleukin-1. But the phenotype of the cell, shown by these various markers, is actually very similar in all the different culture conditions. Looking at the inhibition of catabolism, we see the addition of porcine notochordal cells to degenerate MP cells can actually decrease the level of interleukin-8, an important cytokine. We also see potential increases in matrix production, such as fibronectin, a trend towards a decrease in matrix degrading enzymes, with MMP13 as an example, and an increase in TIMP1, which is an inhibitor of MMPs. And we see regulation of the signalling pathways, which are involved in catabolic signalling, with downregulation of a number of these pathways. So to conclude, if we take human MP cells and culture them in a normal or a degenerate environment, they're actually quite happy. Their viability, phenotype and secretome is very similar to a standard culture media. It's only when we add in interleukin-1 that you see a change in phenotype and the secretome. Notochordal cells, again, their viability and phenotype is very similar in these culture conditions, and it's only affected by the IL-1, and we've shown that there's potential for the notochordal cells to promote a positive action on the MP cells. So I'd like to conclude there by thanking everyone involved in the project, particularly the surgeons, for samples.
Any questions, please? So, Christine, it seems about this interleukin-1 seems to change the whole nature of that, and rather than adding in the notochordal cells, is there any way to turn that media off so that the interleukin-1 isn't being released? And where is it being released from?
So the interleukin-1 is produced by the native cells of the disc, so both the nucleus pulposus and the annulus fibrosus cells. And in an intact disc, it's purely the disc cells that are producing it. You only get inflammation and inflammatory cells when you've got a rupture of the disc. So it is the native cells that's producing it. The notochordal cells do seem to have a positive action on the actions of interleukin-1, and the behaviours that we saw in terms of that the notochordal cells could inhibit catabolism, that occurred as well in the interleukin-1 treated cells. But of course, we've also got the alternative of the IL-1RA gene therapy approach, which we talked a little bit about yesterday. So it's probably likely to be a combination of inhibiting the IL-1 with gene therapy, combined with biomaterials that one of my students talked about yesterday, with an appropriate cell source.
Brilliant. Thank you very much. There's a question there.
Thank you. Have you ever considered...
Sorry, could you mute the microphone up? Thank you.
Is that better?
A little bit.
You may have to come closer to the mic.
Even close. Oh, there we go. Have you considered culturing discs whole?
Culturing discs what, sorry?
Whole.
Whole, yes.
Not monolayer culture, but whole discs.
Yeah, so these cultures were all in 3D alginate culture, where they retain their phenotype. We do also do work with tissue explants, which enables us to use human samples from degenerate tissue as well. And then for the animal tissues, we can do whole organ cultures and some whole organ cultures with cadaveric discs as well. So we are doing the combination of those different levels and layers for the research.
Thank you very much.
Next, we've got Berenda Balain, please.
Thank you very much. Greetings from Oswestry. I'll talk to you about my learning curve experience with full endoscopic spine surgery, minimum 3-year follow-up. I'd like to thank my colleague Sujay Dhirendra, who's covering my own call for this week. Most of you may not be aware, but there is a really nice paper for someone who wants to look into spine endoscopy by Kim et al., talking about the evolution of spine endoscopy and how the different generations are classified. So I'm talking today about interlaminar discectomies and interlaminar lateral stenosis, the second and third generation techniques. These are my first 50 consecutive patients, starting from 2016. Pathology was at L4 to S1 levels, excluded patients with bilateral symptoms to begin with, or patients with facet cysts, revisions, or central stenosis. Average duration of symptoms was 18.5 months. Decent follow-up, L5S1 in 35 patients and L45 in 11. 2 patients had 2-level surgeries. These were my outcome measures, VAS, ODI, EQ5D. I used the SHIMS composite success criteria 1 year after surgery. We used an adjustment for a 3-month ODI score to the 12-month ODI score as per published in the literature. The mean operative time for the L45 level was 77 minutes, for L5S1 longer at 93. Our first case was a protrusion. Our first extrusion was the 9th case, and the first lateral recess stenosis was the 19th case overall. 36 patients had a discectomy, and 8 had a lateral recess decompression combined with a discectomy. I could not do the surgery successfully in 6 patients, 3 because of equipment issues, 2 because there were adhesions between the nerve and the disc, and I found it really scary to mobilize the nerve endoscopically to begin with. In 1 patient, I was lost, and I could not differentiate a very small dural sac from a very swollen S1 nerve root, so I had to abandon and convert to open. Overall outcomes were very good. 90% of patients could ambulate on the same day as soon as they recovered from the GA. None of them had any neurological injuries. The overall composite clinical successful criteria was pretty good at 95%, and everybody achieved MCID as per all the measures. Complications, 2 patients needed a revision discectomy. Another 2 had radicular pain that had recurred but were successfully treated with nerve root blocks. 3 patients had transient leg paresthesia, which took about a week or 2 to completely settle down, did not stop them from mobilizing. There were no dural leaks. Now to the main part, which is talking about learning curve. There are 3 ways you can evaluate learning curve. You can talk about the amount of time taken during surgery. You can talk about complications in one half versus the other half, or you can talk on the basis of the functional results that are achieved. So I divided the patients into MRI-based groups of protrusions, extrusions, and lateral recess stenosis, looked at the overall case number from 1 to 50, as well as individual MRI group-based numbers. Used a number of statistical techniques to look at the learning curves. And if you look at the operating time, the figure A talks about the overall case number divided as per protrusions, extrusions, and lateral recess decompressions. But when you go to within group, you find that the extrusion group doesn't actually change much. It is a protrusion and the lateral recess stenosis which shows a good learning curve. In terms of number of complications, there were 3 complications in the protrusion group. All were in the first half. In the extrusion group, 3 in the first half, 2 in the second half. Lateral recess, there were no complications. Another way to look at learning curve is to look at an ODI score, and these were the same graphs for the first 50 patients, overall case numbers and individual case numbers. The best way to look at learning curve is to look at the 90th centile for achieving, or 90% of the patients achieving your 90th centile for the ODI. So the horizontal line that you see on the right-hand side is the cutoff point of 32 at 3 months for an ODI. And where the line cuts off tells you the learning curve, which falls between 12 to 15 cases for protrusions and lateral recess decompressions and extrusions. So the main learning points are that if you look at the literature for first-generation techniques, it takes them a longer time to achieve an ODI proficiency. But if you look at operating times, you learn the transforaminal first-generation techniques earlier, and it takes you 30 to 40 patients before you become proficient at interlaminar techniques, 2nd and 3rd generation. So final conclusions, the 2nd and 3rd generation techniques are safe and effective. They avoid anatomical problems like high iliac crest, central location of discs, which is a major limitation of first-generation techniques. There's a clear operating time learning curve for protrusions and decompressions. I use inverted commas proficiency. Proficiency takes a much longer time, but for the purpose of the learning curve, it took about 15 cases for functional improvement and 30 to 40 for operating time changes. Careful MRI-based grouping should be done for these patients when you start off.
Okay.
Thank you very much.
Thank you. And we've got a question.
Thanks, Virender. Rajat Verma from Manchester. I think, how do you consent the patients? Because you have 2 potentially equally effective techniques. One is the standard microdiscectomy, and the other one is the endoscopic. How do you tell the patients, okay, fine, you've got this choice. Does the patient make the choice? You make the choice for the patients? And how do you overcome this slight issue with the consent?
Okay, good question, Rajat. I expected nothing less from you. Okay, so this whole idea for endoscopy was presented to the New Procedures Committee. There was a special consent process that I had to go through for the first 20 patients, and the data had to be presented back to them. Special consent was taken from each patient, telling them that this is a new way, endoscopic way of doing things, and they had a choice to turn it down or go the endoscopy route. I was surprised that only one patient said no. Everybody else, because of their experiences with laparoscopic surgeries, arthroscopic surgeries, and their general idea about surgical things moving more and more minimally invasive, patients took it up like anything.
I've just got one other question. In the learning curve that you're talking about, your cases were all done under general anesthetic.
Correct.
So what about the learning curve with moving towards just using pure local anesthetic? You haven't got long. If it's going to be a long answer, I'll come and find you later.
Yeah, I'll talk to you about it later.
Okay. Right, well, we'll stop it there then. Thank you very much.
Thank you.
If we can now invite Roger Comte to come and present his paper, please.
Thank you for letting me speak about my work in the use of machine learning to assess MRI images. We know that back pain is a major burden, and one of the main causes is disc degeneration. We know as well that disc degeneration is assessed mostly with MRI images. Our question is then, can we automate the MRI readings using machine learning? Can these readings be even more consistent? That would definitely ease the health system, and it would increase the data and improve the data for epidemiological studies, such genetic or omics studies. To answer these questions with the systematic research that end up with 27 papers included, most of them analyze different algorithms and check different algorithms, and we saw a preference of using deep learning of these algorithms. On the papers that study that uses different radiologies to assess the ground truth, we find different correlation interpreted kappa values between 0.5 and 0.9. We also emphasize that there's just only 3 external validations on these studies included. These studies included 5 different types of classifications of phenotypes, which are modic change, disc degeneration per se, disc bulge, disc herniation, and the use of Firmware score as phenotype. Here we have a graph where we show the accuracy in the x-axis of different algorithms on the papers, and they are colored through the different classifications types that I just explained. And we can see that visually there's no algorithm that perform better, and there's no cluster of the different phenotypes that also perform better. But that is just a visual comparison. And to make it more statistically, we use meta-regression, which is a kind of meta-analysis. And it confirmed that there's no algorithm that performs better on these classifications, and there's no type of classification that performs better. What we can see again is, as we expected, that external validations perform worse than the developed methods. Also, we can see that preprocessing of the MRIs, such as data augmentation, can improve the classification. One of the main conclusions of this study is that we need improved phenotypes for classification, and quantitative phenotypes that reflects better the progression of disc degeneration is a way to go to this point. As well, in machine learning, the use of unsupervised methods that picks up features that radiologists are normally not using is another way to get to that point. As well, there's many information that's not used in the MRI when we do these classifications. Including these would definitely improve the classification. And machine learning applications, for example, using radiomics, are able to reach that point. I also want to emphasize that we definitely need more external validations to make sure that the accuracy of the development of algorithms perform as they say. Also, I want to know that there's a lack of standardization of the reporting of these algorithms, so there's a need of guidelines. Just to summarize and to finish, this review highlights the need of move beyond the classification of matching the radiologist classifications to some more quantitative and integrative information of the MRI to better classifications. With that, I would thank my supervisor, my co-authors, team, and this for all the support. Thank you.
That was very thought-provoking. Do you have any ideas where that research will take us in the future?
Can you say it again, please?
Do you have any ideas where that research will take us in the future? AI is quite a big field, so...
Yeah, the field is moving forward, but the point is that we have a lot of algorithms. There's many people trying the same things, and we can just reach the agreement of the radiologists, which we know that most of the times is not big. So that's why we suggest to move to unsupervised learning, as Dr. The first presentation, sorry, that he also suggests. And it was interesting to see that they are using these new methodologies on other fields like scoliosis. But in this generation has not been done yet. And I think that would definitely allow for certification of the patients and understand a little bit more the etiology of the disease, how to understand the patient pathology, and at the end, how to make a more specialized or personalized treatment.
Are there any questions?
Could I ask, I mean, as you said, the first presentations we had were about big data and everything yesterday. If you think about how quickly you're acquiring data yourselves in your group, how long do you think you're going to be in a situation where you will have acquired enough data that you might actually be able to say whether or not it is working?
Okay, I'm going to introduce you now the reason why we did that. I'm working mostly with GWASs, genome-wide association analysis, and we need bigger data. And MRI is quite expensive, and people that has MRI and the genotype is quite scarce. So we did that because we want to increase our data set to run more omics and more analysis, epidemiological studies. We are moving that way. We are actually working on that on a big cohort. So it really depends on how willingness are the different groups to share the data. That's one thing that's really important. And the other one is still the performance of these algorithms, as I said. They are developed in a niche population, and how these extract to farther away, for example, from UK to US, is where I think it's still lacking. So that's why, again, it really depends, because surgeons in UK and surgeons in US, they may completely disagree on these phenotypes. So again, when you compare the ground truths for what the machine learning is saying, maybe the machine learning is saying right, but the point is that the ground truths are different. So there's different points to touch before we can definitely move to big data.
Thank you very much.
Thank you.
We'd just like to thank all the presenters for a very interesting session, and we hope you enjoy your break.
Yes.